Hello, good afternoon, and thank you for just joining today's webinar. Yes, you can provide LARC services at your SBHC. An example of successful LARC implementation. So today's webinar is a member-exclusive webinar solely for School-Based Health Alliance members. So firstly, we would like to say thank you for being a School-Based Health Alliance member. We rely on members to support our work as the national voice of the school-based healthcare field, and we pride ourselves on providing resources and trainings that meet your needs. We appreciate your membership. Before I turn it over to our presenters, we have a few housekeeping items to cover. Please help us count. If you're viewing this webinar as a group, go to the chat window that appears in your GoToWebinar window pane, and please type in the name of the person registered as well as the total number of additional people in the room. For example, Aaron Ash +2. All attendees are in listen-only mode, but we do want to hear your questions throughout the webinar. To ask a question, please go to your GoToWebinar window pane and enter the question into the chat box. Attendees will receive an evaluation survey after the webinar. Please let us know how we're doing and any new topics you would like us to cover. Your feedback is vital in crafting presentations for the future. This webinar is being recorded and will be archived on our School-Based Health Alliance website. You can access this webinar as well as all other archives by visiting www.sbhforall.org/webinars. We expect by the end of this webinar, you will be able to identify key themes Neighbor Care Health found for replicating LARC method service delivery in a school-based setting, analyze community and private partnerships that facilitate the delivery of LARC methods in a school-based setting, and identify strategies for integrating a health educator in promoting LARC acceptance and uptake among parents and guardians, schools, and young women in the school-based health center. Today's presenters are from Neighbor Care Health in Seattle, Washington. Kelly Gilmore is a graduate of the University of Washington's Master of Public Health program with 10 years of experience working in reproductive and adolescent health. In 2014, she conducted a program evaluation for Neighbor Care Health to examine their provision of long-acting reversible contraception in 2 school-based health centers. Currently, she is working on a qualitative project to examine factors influencing teen girls' acceptability and uptake of LARC in Neighbor Care SBHCs to inform LARC counseling and outreach protocols for adolescents. Catherine Acker is a graduate of the University of Washington's Master of Public Health program and is the sexual and reproductive health educator focusing on LARC promotion at 2 Seattle High School SBHCs. She has experience organizing, implementing, and facilitating health education programs with youth for 10 years, including 3 years living and working internationally, both in rural and urban settings. In her current role, she has been responsible for dramatic increases in the knowledge, acceptability, and uptake of the LARC methods among adolescents in Neighbor Care Health target SBHCs by implementing and supporting various education and counseling practices. Janet Cady is a pediatric nurse practitioner who has provided school-based health care in the Seattle Public Schools for the past 24 years. Currently, she is the medical director of SBHC programs at Neighbor Care Health, sponsor of 14 school-based health center sites, and the largest community health center organization in Seattle. Janet is nursing faculty co-lead on the University of Washington Leadership Education and Adolescent Health Grant, a multidisciplinary training grant awarded through HRSA. And without further delay, I will turn it over to today's presenters to begin the webinar.
I'll just start by rerunning through our objectives really quick. As Erin mentioned, we're hoping that after today, everyone will be able to identify key themes that we found for replicating LARC method service delivery in the school-based health setting, analyze community and private partnerships that facilitate the delivery of LARC methods in school-based health centers, and identify strategies for integrating a health educator and promoting LARC acceptance and uptake among parents and guardians, school officials, and young women in our school-based clinics. And really quickly before we get started, for everyone that registered, you should have received some key references when you completed your registration. So we're not going to go into detail about the evidence regarding the safety and efficacy of LARC for adolescents. That's pretty well documented. but we did provide some of our favorite references that have been really instrumental in getting stakeholders on board for this. In particular, the American College of Obstetricians and Gynecologists, recommendations for LARC in adolescents, the American Academy of Pediatrics, as many of you know, just came out with an opinion, and the Contraceptive Choice Project and Colorado Family Planning Initiatives have been very instrumental in producing a buy-in for this intervention. One other thing that we wanted to mention is that we just recently looked through the Youth Risk Behavior Survey for our area, and it looks at about 10.5% of teens in Seattle are now reporting using a LARC method, which is great, and higher than the national average of about 2%. So here's our presentation. We've already been through our introductions and the objectives. As I mentioned, there are some key references that were provided to people who registered, and if you haven't had a chance to take a look at those, we highly recommend it. And so I will go ahead. So we wanted to start by just doing a poll and seeing for people in the audience, if you're currently providing LARCs on site at your school-based health center, and if so, what kind? I believe Erin will read the results. So you should see a box on your screen where you can answer the multiple choice question.
Great, thanks, Kelly. So we've launched this poll. If attendees could kindly select one of the answers, we'll give you about 20 seconds. And about 5 more seconds. Great, thank you so much. So I'm showing that about 14% of people are providing both implant services and IUD services. I'm not showing that anyone is providing solely implant or solely IUD. It looks like a vast majority of people on the webinar today, 64% are not providing LARC services at all, and another 21% of attendees are not currently working in a school-based health center program.
Great. Well, we hope that this information will be helpful, particularly for people who aren't providing LARCs at this time. A lot of what we're presenting today is about the implementation, and the second webinar that we'll be presenting, I think sometime in March, will be more about clinical processes. So I'm going to go through, in our presentation today, we're going to go through the stages of implementation in our school-based health center program. I'm going to go through the important factors that are in place in the Seattle area, and then turn it over to Janet, who's going to talk about engaging key stakeholders and skill development for school-based health center providers. Katie Acker, the health educator, is going to talk about integrating a health educator in a school-based program and some of our successes and next steps. And just again, really quickly before we get started here, our second poll question was, what is the biggest barrier to LARC implementation in your school-based health center, which should launch another multiple choice question poll.
Thank you, and attendees will now see the second poll on your screen. If you could kindly respond, we'll give you another 20 seconds. I can see people are still responding, so we'll give about 10 more seconds. Great, thank you so much. So it looks like attendees indicated that other challenges were the largest barrier to implementing LARCs in this SBHC. 33% said other challenges. That was followed by organizational barriers at 25%, as well as training and skills development of providers also at 25%. Finally, I'm showing about 17% of attendees selected that financial support, billing, and funding was the biggest barrier.
Okay, great. Thank you, everybody, for answering that question. So hopefully some of this information will be helpful then. I'm just going to go over some of the factors that we have in place here in Seattle and with our school-based health center program that we think has really been key in implementation of LARC services. Certainly one of the facilitating factors we have here in Seattle is the fact that we've established school-based health centers on site in nearly every Seattle public school. They're partially funded through a voter-approved levy that I'll touch on in a minute, and they're operated by a variety of healthcare organizations around the city. And you'll see that the first one was started in 1988, and NeighborCare's first school-based health center was introduced in 1992. So at NeighborCare Health, they operate 12 school-based health centers in the city. They operate the most school-based health centers of any sponsoring organization, 3 of which are high schools and 3 of which are middle schools that have been offering LARC services since 2010. And the fact that these health centers have been established for many years within the schools and have good relationships with the schools has made it possible to provide these services. Another big part of the factors in place here is internal and external support and partnerships. In particular, NeighborCare Health's senior leadership has been very supportive and trusting of their school-based health center staff when they ask to expand their contraceptive services and provide LARC methods. School-based health center staff presented evidence about the safety and efficacy of LARC, particularly the ACOG recommendations, to NeighborCare Health leadership, and were given the go-ahead to expand these services within their program. A second partner that's been really influential is the University of Washington's OBGYNs and family planning doctors and the University of Washington School of Medicine Adolescent Health Leadership Education and Adolescent Health Grant, otherwise known as LEA. So NeighborCare has been able to ask these partners for advice and resources throughout this process. For example, a wonderful family planning doc at UW has offered her time to school-based health center clinicians, and we're able to call her to consult when they have questions about LARC. These partners have been conducting family planning research and adolescent health research and providing IUDs for teens for years and have been advocates for this program in the broader community. They've also lent their expertise, as I mentioned earlier, to the providers themselves and certainly credibility to this idea. Our third key partner is Public Health Seattle and King County, which I think it's safe to say none of this would have even been possible if it weren't for the forward-thinking people at our local public health jurisdiction. In 2009, they received a small grant from the National Campaign to Prevent Teen and Unplanned Pregnancy to promote LARC methods in young women. Here in Seattle, Public Health Seattle and King County manages the contract with healthcare organizations that sponsor school-based health centers within Seattle Public Schools. So they went to the school-based health center providers to see if anyone would be interested in receiving free training and support to provide LARC in higher middle school clinics. And initially, no one was interested. Even the school-based health centers that are sponsored by Public Health didn't want any part in this, and NeighborCare was the first organization to come around and say, yes, I think we're going to give this a shot. So I think it's important to note that even in this favorable progressive bubble that we live in Seattle, this was not a popular idea at first, and it took time and convincing for people to come around to it. So our next big factor that we have in place here in Seattle that we are very, very lucky to have is Washington State minor confidentiality laws. In particular, minors in our state may obtain or refuse birth control services at any age without the consent of a parent. It's standard practice for NeighborCare school-based clinicians to counsel all teens on discussing sexual activity or plans for sexual activity with their parents. Neighborhood providers really like using the Relationship Redux booklet, which gives teens and parents tips about talking about contraception and sexual activity. It was produced by the National Campaign to Prevent Teen and Unplanned Pregnancy, and I believe is available on bedsider.org. This program, I think, would still be possible even without the minor consent laws. At first, when NeighborCare was first piloting LARC, they only provided LARC devices to teens whose parents were aware that they were going to be receiving this service and on board with it. However, this law obviously lowers a significant barrier for many teens. And I'm sure you're all very aware of the teen confidentiality and consent laws in your state, but in case you need to look them up again, the Guttmacher Institute has a great resource where you can view your state's confidentiality laws, and the link is on the slide here. I think as a third big factor for us has been financial support. So there's not one financial piece that's supporting LARC implementation in school-based health centers. It comes from a variety of funding sources. The first and most important that I alluded to earlier is the voters in the city of Seattle have approved a property tax levy every 7 years since 1990, which is called the Families and Education Levy. And in this levy cycle, about $44 million of levy funds are used to support school-based health centers within the city. This money covers, on average, about 1/3 of the operating costs of school-based health centers. A second big piece is the billing of Medicaid and private insurance. As I mentioned before, school-based health centers in Seattle are operated and staffed by outside healthcare organizations. There's about 5 of these organizations that operate within the city, and not all of these agencies are set up to bill within their school-based clinics. NeighborCare has a billing process set up for their school-based clinics, which means they're able to bill state Medicaid programs or private insurance for the cost of a child's visit. Another Medicaid part is that in the state of Washington, we have a carve-out program called Take Charge, which covers any method of birth control for low-income women and for teens who need confidential reproductive health services. The reimbursement for LARC devices on Take Charge is about $600 per device right now, which is less than the purchasing price, obviously, but certainly helps in this program's ability to provide LARC services to these teens. And then a fourth funding source that we have is a grant, or actually a private funding source. So NeighborCare was very lucky to be approached by a private donor community in 2012 who asked what they could do to help increase the impact of LARC services within the school-based health center. With this money, they've been able to support one full-time health educator, Katie, who will speak shortly about her work in the health education. And from here, I'm going to turn it over to Janet Katie, who's going to talk about engaging key stakeholders.
Thank you, Kelly, and thank you to those participating in this webinar. It's an exciting opportunity for us to share with you some of the progress we've been able to make implementing best practices into our school-based program. So one of the things I wanted to just start out with was, outside of having our senior leadership support, which was key to us being able to move forward, the other thing we knew was that we needed to be communicating with school administrators and families. We've always been very public about the services and the scope of care that we provide in our school-based programs, including mental health, oral health, and medical care. But we felt like it was an important time to meet with the principals and their administrative support team to let them know the value of expanding this service. So one of the things we focused on was the key demographic who drops out of school, and that is pregnant young women and women who are parenting, and often for young men as well. So what we chose to do was to focus our expansion when we talked with both parents groups and with the schools on the issues of dropout prevention and graduation rate impact on the school. And the schools and parents were already very well aware that reproductive health and sexual health education was part of the scope of what we provided. And so by then being able to talk about the data that shows the remarkable retention of LARC methods as well as the pregnancy rate difference, we were able to have every audience we presented to feel like this was right work, right role, and they were glad we were taking it on. Then in addition, we did meet with parent groups and followed up by putting notices into parent emails and parent letters. As you know, clearly not all parents come to parent school-based meetings, and so we wanted to be clear about the fact that this service was being added. And one of the ways we did that was to talk about after high school readiness at one school. Another school talked about impulsivity and brain development in adolescence, and wanted to amplify the fact that having LARCs on board takes away that impulsive decision at the time of sexual activity. And then I just want to highlight that one of the other things we did was really focus on the non-contraceptive benefits of long-acting reversible contraceptives. And our goal in that was to say that in general we're trying to destigmatize healthcare, whether that's mental health, medical care, or oral health care, but we also wanted to not stigmatize people who were seeking a LARC service as necessarily being sexually active, and we know there's many other benefits. So now I'm going to talk just a few minutes about the clinical practice and how we worked on this as a provider group. So what we did was, as a provider team, after what Kelly mentioned was we had a small grant partnered with public health, we were just doing our own learning as clinicians. This was a real change in practice, from when many of us were young and seeking our own contraceptive advice, as well as any of the clinical skills that we had in school-based care. So one of the things that we did was make referrals in the first few months of the program, and through public health, collecting data from all of the school-based sites, what we know is that less than 50% of young women that were referred to an external provider for a LARC actually made that appointment and received the LARC service. So that was motivation for us to figure out what barriers do we need to address in order to do this in-house. So one of the things we did was meet as a provider group. We looked around and we had a range. We had a range of clinicians, from people who were very experienced doing LARCs and IUD insertions to people who were novices. We also had people who felt like it was the right work and people who were really hesitant and were concerned about the expansion of this care. So what we did was talk to the people who we considered the early adopters, people who were willing to safely learn and share what they learned with the rest of the group. And what we did was go through a checklist of skills provided by Public Health Seattle-King County that was a skills-based learning. They were able to do hands-on mentoring at a public health site, and then in turn that public health expert came to each of our school-based sites to look at our setup, look at our equipment, and do some some shadowing and expertise mentoring at the site. And we found that very helpful to contribute to the change in practice. So what we did was, it was remarkable and really rewarding, is that the people who went first, and like Kelly mentioned, we had parent approval and knowledge of the first LARC services we were providing in 2009-2010 school year. And what we learned from that was that the sky didn't fall in. Clinicians felt like it was the right work. They found it rewarding and were able to provide a LARC to young women, and we talking about that then with their clinician colleagues. And within just a few short months, we had other people in our team saying, I'm ready to learn, I'd like to do that, I can see the value, and move forward with wanting to learn the skills. So the initial skills were some hands-on mentoring and actual services and the safety of what we wanted to be providing. Our nurse practitioner and PA team work without MA or RN support, so these were providers working solo, and so wanting to adapt what we knew worked in some other sites to our care. And like Kelly also mentioned, we worked and consulted with the University of Washington physicians and physicians in our own organization to review our standard of care. And then the second part, which Katie will be talking much more about, was doing tiered counseling and learning how to present LARCs in an effective way. I think what we've learned over the period of time, we've done over 415 LARC services in our school-based program to date, and are on track to, we've implemented remarkable increases, which we will talk more about as well. What we have found is that if we do the work of preparing, we have skilled clinicians who are ready to practice, and we present the information to adolescents in a way that is safe and effective methods in the tiered counseling, they say yes and they agree to the service. So I'll pass it on to Katie, and she will continue to talk to you about our counseling and her role in our school-based program.
Yes, thank you, Janet. Yes, so I am the health educator at 2 of our school-based health centers here in Seattle, and I'm going to speak briefly a little bit about my role as the health educator, specifically working at LARC education and outreach with our schools. And so kind of moving through there, I'll touch on, again, what Janet had said. But I wanted to start kind of here with the what is a LARC. So one of the first things that I saw starting my role last school year was the need to really kind of continue and start those conversations. So we had all of those conversations and the trainings and the skills building and those attitude shifting happening within our provider population. So all of our school-based providers were on board and doing their LARCs and having their counseling sessions. But one of the things that we needed to amplify was me coming in and really kind of bringing those conversations outside of the exam room or outside of the counseling room. So even though I'll meet with students one-on-one, one of my favorite things to do is really kind of be visible. And that's through a multitude of different ways, just being visible in the school, but really also kind of starting those conversations. So sitting out in the waiting room and just talking with people who come through, meeting people in different, walking through the hallways, meeting with different school admin, teachers, students, and just kind of starting the conversation about LARC. So you say LARC and most people aren't even going to know what that is. And so it's really kind of expanding upon those type of things. Going to the school events, going to the staff meetings. I don't just go to one staff meeting, go to more and more and more. So I went to staff meetings all last year, started going to them this year. The third one I went to this year, I still had teachers coming up to me completely shocked that I even had my job existed. So it's that constant kind of reminder of LARC services are there. We're there to support students in those reproductive health decisions. And then kind of going from the what is a LARC, it's really addressing a lot of those myths and concerns. So starting out any type of LARC implementation, there are myths and concerns by students, by parents and guardians, by school. We hear even by certain providers. There are providers who opt to have that shift of kind of the counseling and what they are seeing as should and can be done. And so really addressing a lot of those myths. And so from students you hear a lot of the, well, my friend told me this, or my mom said this, or when my aunt had it, this happened. And so it's addressing a lot of those concerns. Or of course, one of my favorites is, you know, I read online or I saw online. And so we know we can get all kinds of fun questions from students about things that they saw or read online. And the same thing with parents and guardians as well. I mean, we hear ads on TV about lawyers coming up and trying to bring up different cases about things being dangerous. And so you hear, you know, oh, there's too much hormone or they're dangerous or those type of things and concerns that parents might have. And so it's addressing a lot of those concerns. I can honestly speak that type of concern, I haven't had very much parent pushback in my role since I've started. I think more often than not, we are more nervous about the reactions that we might get and sometimes don't jump in and take it further. And I think more than anything, I've gotten a lot more positive feedback from parents and guardians and school staff. A lot of adults are a lot more receptive to the idea that the youth are being more responsible in their decision-making process and in their sexual and reproductive health, which is really awesome to see. So just kind of briefly, I touched on a lot of the things I do in my role, but the majority of my role is spent in doing kind of one-on-one visits or counseling. And Janet had mentioned that shift in how we counsel students and patients on contraceptives and how it is shifting to more of a tiered counseling. And that is an idea that is based off a lot of, we referenced the Choice Project, and I think it's a great, if you haven't already looked through it, it's an excellent reference. It's a lot, there's a lot of key points to pull from a lot of the stuff that they had done. And they started talking about that tiered counseling where you start from the top, those most effective methods and most recommended methods, and kind of tier it and then kind of jump down. And I have a really incredible resource that I'll reference in just a few minutes to kind of show what that might look like for a lot of people. But that's a huge, important piece there is that counseling piece. I do a lot of visits, have student groups, and so those aren't specific to sexual and reproductive health. That's going in and jumping to already existing student groups within the schools, which is really fun and important. I know one of the big ones that I like to mention too is one of our schools does have a group of Latina women, and we know demographically speaking that that population is one of our most at risk and one of the populations that does have the highest rates of unplanned pregnancy. So just by kind of going there and doing outreach and talking with those students, we've seen a pretty notable uptake in those methods amongst our Latina girls, which is really great. I mentioned going to a lot of school meetings and events and just constantly being visible and present, which is really, really important, I think, for this role. It's not just kind of isolating yourself into a clinic, but it is getting out if you really want people to be on board and know what's happening and know about these methods. Kind of jumped over, but classroom presentations, of course, I take every opportunity I can. I try my best to seek out those teachers of classes that are particularly relevant. So we do offer health classes in our high schools, and those health classes do have a sexual health unit, and teachers are very receptive to me coming in and talking to their students about those topics, which is really fun, but also seeking out those additional classes that might reference it. So classes like a life skills class or a home ec type class, a lot of times they'll touch on those parenting, teen parent type things, and it's a good opportunity to also kind of get in there and talk with students. Parent meetings, so I do continually try to attend as many PTSA meetings as I can, and again, just being visible as a person showing invested interest in their students' well-being. It's not, very rarely am I going to a meeting giving a talk. It's just really kind of being present and showing our presence. And then, of course, the social media. We know how youth are with their social media and how their phone is just another appendage on their body. And so we've really kind of in the clinics been trying to up our tech-savvy selves there and post various health-related topics, but every now and then throw in a zinger about birth control or reproductive health, which has been pretty well received and fun as well. And jumping on. So one of the things, we use the term shifting a lot. So there is the shift in the attitudes, but with the providers and that shifting kind of comfort levels. And it's a process, so LARC implementation is of course a process, but one of the other things I wanted to touch on is kind of the shifting of this norm that we speak of. And just in the last year that I've been in my role, actually a year and a half now, just noticing the huge shift in what is becoming more of the norm or what's becoming comfortable for students. And so gonna kind of mention the choice project again. So one of the other things that they had discussed in their results and kind of their outcomes was that, it wasn't just the provider or a health educator or counselor, a contraceptive counselor that were all knowledgeable and knowing about these methods and able to talk to students about these methods. It really was every person that the patient would come in contact with. So one of the big things that I know at both of the schools that I'm at that is in place or has kind of expanded is that everybody really is aware of these methods. So there is a bulletin board in each of the schools that has a birth control method of the month that happens to be a LARC pretty much every month or every other month at least. And when students come in and they can simply ask, well, what's that? Our clinic coordinator right there at the front desk is able to answer the question. So it's not something where the person at the front desk or the first person they see has to say, well, I can let you talk to this person about this, and this is able to be addressed kind of right then and there, which is really incredible. And so any questions students have, oftentimes they can be addressed, before kind of having to go through a process of making further appointments, which is great. So it's not just our clinic coordinators, but our mental health counselors. We have mental health counselors in our schools who I've also spoken to and who have gained a lot of knowledge on these LARCs since, and that was fun to talk with them kind of about their thoughts and what they knew about contraceptives. And I've gotten referrals from mental health therapists in both of our clinics as well. So really kind of expanding that clinic knowledge and enthusiasm of these methods has been really great. I mentioned the counseling strategies that was echoed in the Choice Project about the tiered counseling, so I won't talk a little more about that one. And then kind of jumping down, one of our favorite things, and I really love this, but these conversations about birth control are just becoming more and more visible and public amongst the student population, which is really, really wonderful to see, and I can't say enough about that. Students, birth control is not as taboo. It's becoming more popular and more noted and more exciting to be on, and you're seeing more and more kind of pride. Girls are really proud of their methods. Like, they are, loud and proud. They are making sure people know about the methods and what's so wonderful about them. And it's kind of becoming trendy. And I know this is echoed in another area, a Seattle area provider had also mentioned seeing a similar thing in her school, where there's like little groups of students who are now we have one group of students at one of our schools that call themselves the Nexies. So that's been kind of fun to see that kind of evolve. So I'm here to help all this stuff, but it's really kind of been handed over, and the students and kind of our other staff have really kind of taken over since then. And then finally, that shift in norm there that we see, a lot of times one of the first questions we'll ask students when they come in for contraceptives is, what's the main thing you're looking for in birth control? And probably still 50%, 60% of the time it is not wanting to get pregnant, but we're seeing more and more, and this is definitely anecdotally. I know we're working on, and I'll discuss it in just a moment, but working on kind of tracking this. But you're seeing more and more students coming in and, one, starting birth control before they've ever had sex, but two, really looking for a method that has these non-contraceptive benefits that we mentioned. So I'm seeing more and more girls coming in and asking for that thing that lasts a long time that can stop your period. So it's really been a shift in that too, and what people are looking for in a contraceptive method. So this is just some of our favorite resources here. I talk a lot about Bedsider. It has a lot of great information on it. This is the sheet I referenced that I think is excellent, an excellent guide for people who are looking at doing kind of a tiered counseling technique, and it has the methods tiered there, and it's great to go through, and this is easily accessible on their website. So finally, just kind of talking and touching on the successes and next steps of the program here that we've had, and we've kind of touched on some of them. So the chart on top there is our LARC insertions up until last school year. So our total up until last school year was about 346, and as Janet mentioned, we have done over 400 total as of, I think, today when we checked it. So we are on track to on track with our goal and to kind of exceed that insertion rate that we had from last year, which is wonderful to note. And so these insertions are going up, and are going up pretty dramatically. One of the things that we're pretty proud of here and working on kind of improving our evaluation models and looking at how we're tracking things is when we started LARC insertions in 2010-2011 school year, there were about 2% of the females using the school-based health center for contraceptive services had a LARC. At the end of last year, about a third, about 30% of all the females using our school-based health center for contraceptive services had a LARC, which is really, really incredible to look at and see there. And we're hoping we're going to see that number continue to rise as we move forward. So quickly, some of our other next steps. So we did recently receive funding this year for a new health educator position, a second health educator position, which is very, very exciting. And that was through a separate grant that we received. And this person is was hired earlier this month and is now working in our another one of our high schools. So we will have a health educator in all 3 of our high schools. And then also with our homeless youth clinic, which is another, as we know, another high-risk population, especially in terms of the unplanned pregnancies. And then finally, looking forward to some more opportunities that we're exploring and going to be moving forward with is one of the things we want to do is really looking at telling our story and looking at how we're going to tell it through improving some of our tracking and evaluation models of our LARC story there. So right now we're really tracking our LARC insertions, and we know at some point that number is going to stop going up because we're hoping that people will have their LARCs. And so just looking at insertion numbers is, we know is not going to be our most direct way to reach or look at kind of our success of this program. So it really is looking at, what is our percentage of students using our school-based health centers that are on a LARC method. Another piece is really continuing to do that parent education piece, and that's something that is a challenge, especially as the older students get, to kind of outreach to parents, but continually kind of hitting those parent pieces is really important, and we always are trying to include parents in decision-making processes of the students. As we mentioned, Washington State is not required, but it is something we're always working towards trying to incorporate into our practice. And then the final thing we want to mention is we are going to be doing a second webinar, kind of a part 2 to this, but it's going to be more specifically focused on clinical practice, clinical skills and practice, which I know we've had a lot of questions around those pieces there, and so we hope that that one will really address a lot more of the specific skills and practice that we are using, and that we hope you guys can then kind of take into your practice there. And then I think that is all. So we just wanted to thank School-Based Health Alliance and Erin and Amber for helping us get this all set up all through our technical difficulties. Sorry again about that, but thank you very much for sticking with us. And so we just want to open it up to questions at this point.
Great. Thank you so much, Kelly, Katie, and Janet. This presentation has been really insightful, really informative, and congratulations on the successes of your program. I think that this is certainly a topic of high interest, particularly given the American Academy of Pediatrics updated guidelines that were released late last year. And it's really been interesting to learn about neighbor care health and the challenges and barriers that you had to overcome in order to get your program where you are today. It's very encouraging. So thank you for your successes, your best practices, and your advice. Attendees, if you have any questions for Kelly, Katie, or Janet, you can go ahead and type them into your chat box that's located in the GoToWebinar window pane. And we'll give you just a moment here to think of any questions and submit them. We have our first question, and so the first question is, did you have any angry parents, and how did you handle that?
We have had, out of the 415, if a parent is dissatisfied with the care or has concerns about our practice, the clinicians refer those calls to me. And I have fielded one call from a local parent. We do know of some young women who, when we talk about contraceptives with young women, we talk about when are you going to be able to talk to your parents, not you don't need to talk to your parents. And so sometimes young women or then decide to reveal that they are using a LARC, and we have had some young women feel pressured from their parents to have them removed. And although we do follow up with the young women and know that we've taken out very few, we have heard from a couple young women whose parents took them to their personal provider and insisted that the young woman remove their Nexplanon in particular. But those are like 3 cases out of the 415. And we've had other parent concerns about birth control or our availability of condoms, but specifically around our LARCs, it's been very, very few.
Great, thank you. I know that that's a challenging question and something that's on a lot of people's minds, but certainly an important question to discuss how to handle that situation if it should arise. We do have a few more questions rolling in. So the next one is that you mentioned a relationship book as a reference for working with youth. Can you remind us of what that is and where we can find it?
Thanks. So it's called the Relationship Redux, R-E-D-U-X, and it's materials that are available through the national campaign to prevent teen and unplanned pregnancy. I believe it's easily accessible on their website. I also believe it's on bedsider.org, and I will make a note. That's something that, Erin, maybe we could send to you to have available for folks after the webinar.
Absolutely.
I'll just add, this is Janet, that it's a resource that actually encourages parents to have conversations around relationships, around sexual health and decision-making prior to sexual activity. And so that's been a resource we've used when we've talked with parents just to help get, and there's some dialogues in there for practice that I think parents have appreciated.
Great, thank you, and we're happy to make those resources available to attendees. We have another question. Is there anyone who follows up on LARC use in the teenager or who potentially removes the IUDs and implants if needed at your school-based health center?
This is Janet again. We definitely do our own follow-up, and we also do our own removals. We've had very few removals. I think we have had some Nexplanon removals, and honestly then those young women usually selected that same day to have an IUD or the Nexplanon replaced. I think one of our priorities is to do really good counseling between Katie and the clinician role to make sure that young women have an ability to cope with some of the side effects that they may be facing. And as a way of just supporting them and understanding what are the potential side effects that we need to be prepared to respond to, and what are some young women linking in their lives to a reaction to their birth control method. We do quite a bit of follow-up, generally see young people back within a couple weeks, and then within 6 weeks to make sure that we're answering any questions. And then after that, we have some handouts that are in our protocols we shared, and young women are welcome to come in at any time and talk with Katie or one of the clinicians. And then we have removal protocols as well, and I would say, have, out of all of our sites, I think we feel like they're we're in our 5th year. I think we've removed 5 total that didn't have a replacement on that same day.
Great, thank you. So another question that we have is, what are some good ways to get teacher buy-in and support for providing LARCs and contraceptive at the SBHC?
Well, I'm going to let Katie take that one.
Yeah, so the teacher buy-in and school support. So I came in after a lot of those conversations that Janet had mentioned were already happened, where the LARCs already been implemented in schools for a few years. And so my coming in, I think, was a lot more, like I mentioned, kind of making it just a little bit more visible and having people a little bit more knowledgeable of the resources. And so in terms of kind of getting them on board, not really much, never having been on board in my experience, honestly. So I think a lot more of it was just kind of, I know in my conversations that I've had with admin or the new admin coming in who might have been kind of onboarded since the LARCs were implemented, or other teachers, and talking with them, the initial response is, oh, well, we do that. Oh, and so it's just kind of like shocked, but I've not had any kind of pushback. If anything, I think they're pretty excited and more than eager to refer students. I've met with a couple teachers who, asked me about things, and one teacher has said, oh, I've been referring my girls to Planned Parenthood for so long. It's so great that you're here. So I can't really speak in terms of having any real pushback from teachers. or admin for that matter. It's really been a lot more of just kind of letting them know in that initial shock that they've had or initial kind of response. But other than that, they've all been very happily on board.
And now we're going to transfer to Kelly.
I guess I have one thing to add from the historical perspective is that Public Health Seattle and King County also has developed a sexual health education curriculum that's used in Seattle Public Schools, which is called FLASH, and they have updated that to reflect guidelines as LARC being the most effective and recommended methods for teens. They also do a yearly training with all of the health teachers, so they are getting that information on a yearly basis, so that probably has to do with the lack of pushback there.
Great, and I think we have time just for one more question. I do want to be cognizant of everyone's time this afternoon, so the final question will be, are LARCs placed during school hours or after school time?
That's a great question. We do it throughout the day, depending on when it works out best for a young woman's schedule. We've had almost all of our young women be ready to go back to class after they rest in the clinic for 10 to 15 minutes. We do them after school, and that's, we have had parents come to the clinics to be with their daughter while they're having this procedure, and so I don't think I've done any before school, but during school and after school we make appointments for young women to get the procedure.
Great, thank you very much. And again, I would like to say thank you to today's presenters. This has been a really great presentation. And I would also like to say thank you to the attendees for hanging with us. I don't think anybody dropped off during our technology issues, so we really appreciate that. And we hope that you found this webinar as insightful as we did. So closing reminders for today, this presentation has been recorded and it will be archived on our website in the next 2 to 3 business days. If you would like to request additional support, ask additional questions about LARC services, please send us an email at programs@sbhforall.org. We'd like to ask you to take a moment to fill out 3 additional poll questions that will appear on your screen. Please let us know how we're doing. And we will also be sending a brief post-evaluation survey within the next 2 to 3 business days. We'd love to hear your feedback and ideas. And lastly, we'd like to say thank you for joining us today, and we hope to see you on the second webinar in this series about LARC services, so please stay tuned for more information on that. So the first poll question will be, did this presentation meet your needs? And 5 more seconds. Thank you. And the second question, did this presentation provide you with usable ideas and or techniques? And just about 5 more seconds. And the final question, would you recommend this webinar to others? Five more seconds to respond. Thank you so much to everyone for attending this webinar and for responding to the poll questions. And again, thank you to Kelly, Katie, and Janet for a great presentation this afternoon. We hope you all have a wonderful day.